Thank you, Dr. Wong. Our final speaker for this session is Dr. Abby Besemer. She's also a physicist in our group and a fellow Wisconsin grad. And she's going to be talking to us about advanced imaging applications in radiation therapy. And at the end of this talk, we'll take questions for all the speakers in this session.
All right, thank you. So to start, I have nothing to disclose. I'm going to briefly talk about several advanced imaging techniques in radiation therapy, focusing mainly on those relevant to CRM-Linux as well as MR-Linux. So first, we're going to talk about several techniques used during CT simulation. So metal objects can cause photon starvation and beam hardening objects or artifacts. This is going to lead to challenges in ROI contouring, erroneous CT to density values that can cause large errors in the dose calculation. So MAR methods use various reconstruction techniques. Well, this is an actual old version. Sorry, I'm going to have to stop it. The other one's very long. Yeah, there's one I uploaded this morning. Okay. Okay. I do have my zip drive right here. So the other one is a lot longer, so I'm going to have to change it. That looks more like it. All right, so metal artifact reduction is a reconstruction algorithm that can be used to reduce these artifacts. MAR methods are really easy to implement clinically. You can just acquire your CT simulation scan like normal, and then add an additional MAR reconstruction. Also, you don't need to commission an additional CT to density table in your treatment planning system. Some challenges are, though, that it doesn't always remove all of the artifacts, and sometimes it can cause additional artifacts itself, but generally it still offers a significant improvement. And then also the borders of the metal object itself can still be somewhat uncertain. So MAR methods can help us reduce the artifacts from these high Z objects. But what do we do about the fact that the HU for most metal objects is actually higher than the maximum HU allowed by our scanner? So typically we're going to have to manually contour the object and override the density, as you can see here, for this high Z magnet in this breast tissue expander. Obviously this is going to be tedious and imprecise. So an alternative method is to simply reconstruct the CT scan using an extended 16-bit density scale, and compared to a 12-bit scale, this is going to give us a max HU of around 30,000 compared to 3,000. In order to use this in your TPS, you're first going to have to create an expanded HU to density curve by scanning a phantom with high Z inserts. Several studies have performed experimental measurements and planned comparisons using manual density overrides and versus extended density CT images like the one shown here. And in general, the extended density CT agreed better with the measurements and was shown to be sufficiently accurate for high-Z dose calculations, as well as being more efficient. Next is bolus tracking. So most often your CT scan is going to be acquired at a fixed time after a contrast injection, when that contrast is expected to arrive at your desired location. A challenge with fixed timing may be it may not be optimal for every patient, and we may miss that time of optimal enhancement. So an alternative is to use contrast bolus tracking, and this has been shown to improve target delineation over fixed time delays, especially for abdominal targets like the liver and pancreas. So bolus tracking works by tracking the patient-specific kinetics of the contrast to trigger the CT scan. So you can see here in this protocol, there is first a pre-monitoring scan, and this is a single slice scan, and it's used to draw this contrast monitoring ROI, which is shown here in the abdominal aorta. And then after the contrast injection starts, the monitoring scan will rescan the slice every few seconds. Once the HU value reaches a certain threshold, the contrast scans will then start after appropriate time delay. Implementing bolus tracking is fairly low risk because there's only going to be a small increase in the simulation time, and you're only going to track that bolus on a single slice, so the increased dose is very small. Bolus tracking has also been combined with several other techniques like 4D CT and dual energy CT, which I'll talk about next. So dual energy CT is a technique that acquires two sequential or simultaneous CT images using different kV energies. So here you can see there are several ways to acquire these images, including a dual source, two sequential scans, split source using filters, dual layer detectors, and then fast kV switching. So dual energy CT takes advantage of the fact that the attenuation properties of soft tissues are going to change with different energies. So Compton scattering is going to be your dominant reaction in soft tissues, and it's relatively independent of energy. However, the attenuation from the photoelectric effect significantly increases at lower energies and for high-Z tissues like your bone and your contrast. So the data from the images acquired with these two different energies can then be post-processed and reconstructed to kind of give us more information about the tissue properties rather than just an HU value. So one way to post-process the image is to create a virtual monoenergetic images. These are meant to reflect the attenuation as if it was acquired at that single photon energy. So you can see here a range of images from 40 to 180 keV. And in this case, the 75 keV one actually resulted in the highest contrast to noise ratio for the tumor. So this one could be the one that would be used to aid in tumor contouring. And then you can see on the left that generally the lower energy images are going to result in the best soft tissue contrast, but they are also going to have the most amount of noise. And then on the right, you can see that the high energy images can also be used to help with metal artifact reductions. However, typically MAR methods that we discussed earlier are actually preferred for this application, since some dual energy acquisition techniques like dual scanning can suffer if there's going to be any movement between or changes in the anatomy between those two scans. So in an effort to utilize both the improved contrast from the low energy image and the decreased noise from the high energy image, we can generate a mixed image shown here on the right. And this is typically comprised of about 60% of the high energy data and 40% of the low energy data. Dual energy also allows us to perform a material decomposition, where we're going to calculate the composition of a given voxel by figuring out how much attenuation is coming from these different materials. So once we create these decompositions of, say, soft tissue, iodine, bone, we can then reconstruct the CT to emphasize or subtract out different components, which I'll show next. So here's an example of iodine maps that are reconstructed using material decomposition. You can see that it's hard to assess the amount of contrast relative to the kidney in the contrast CT in the middle. But the iodine maps on the right make it clear that this one on the top, there's not much uptake in this lesion, and a biopsy confirmed this was a cyst. But on the bottom, it has a notable amount of uptake, and that was confirmed to be renal cancer. Now we can identify the iodine contrast of each voxel. The iodine can then be removed during reconstruction to create these virtual non-contrast images shown on the right. These can be useful for treatment planning, which is usually going to require us to acquire an additional non-contrast CT scan or manually override that density. And several studies have shown that generally the dose differences between treatment plans using non-contrast and virtual non-contrast images are pretty small, but you can see there are definitely, it's not a perfect representation, so they should always be reviewed carefully. And then there are numerous other applications of dual energy CT, which unfortunately don't have time to cover today. Some additional challenges of dual energy CT are that it's going to require additional hardware and software, which is typically not integrated into the scanner or the TPS. It has field of view limitations, so it may not be ideal for larger patients. We need more studies verifying dose calculation accuracy. And there's not yet standard recommendations for commissioning and QA. So institutions have to be sure to evaluate and validate its use for clinical applications. All right, so as we all know, MR images have superior soft tissue contrast, and they're often registered to the treatment and planning CT in order to contour your target and your normal tissues. An alternative workflow, though, is to use a MR-only simulation. Now, one of the main reasons that we use a CT for treatment planning is because it's going to give us a map of the tissue densities so that we can calculate dose. So what do we do if we only have an MR image? Well, there are two main options. The first is to do a bulk density assignment where you can manually assign the densities for each structure based on contours. Obvious disadvantage of this is going to be a very manual and time consuming. Another option is to use a synthetic CT image, which are going to be created directly from your MR images. These images are typically simple, only segmented into a handful of tissues. We recently got this feature here at UNMC on our 1.5T MR scanner, and the images here show that dose differences between the CT sim and the synthetic CT are pretty small. And other studies have shown for sites like the prostate, the differences are typically less than 1%. And in fact, Memorial Sloan Kettering has now switched over to using a MR-only workflow using synthetic CTs for all of their eligible prostate patients. Some challenges to keep in mind when you're doing MR-only sim is that simulations can be time-consuming and kind of burdensome on a very busy MR scanner. You need a laser system installed, and then you also have to have a mobilization equipment that's compatible with the MR and with the coils. There are patient indications like implanted devices, patient size, claustrophobia. There can be geometric distortion and other MR artifacts. And then lastly, therapists and MR techs need the appropriate cross-training in both MR and therapy. Now we'll move on to the in-room imaging techniques. So the first is surface-guided radiation therapy. So SGRT is an optical imaging technique used to minimize both intrafraction and interfraction positional uncertainties. And it uses a set of projectors that are going to project an optical pattern on the patient's skin. And then several cameras can reconstruct the 3D rendering of the patient's surface in real time. The main draw of SGRT is that it's non-invasive and that there's no radiation dose. Also, some vendors have similar optical cameras that can be installed in CT sim for acquiring an external surface at the time of sim. The most popular application of SGRT is for breast, but it has been shown to reduce setup and positional uncertainties in a variety of sites. These plots are from a paper by Stanley et al., which compared the setup accuracy relative to a cone beam CT for SGRT shown in red, and then 3-point BB shown in blue for over 6,000 treatments. And you can see that SGRT generally resulted in much smaller shifts, generally less than a millimeter. So when SGRT is used for patient setup, the typical procedure is to align the patient to a reference surface using the shift and rotation deltas that are displayed on the SGRC system. So there's several options of what to use for that reference surface. The first is the external surface from the CT DICOM image shown here on the top. Typically this is the standard, it's gonna be the best quality. The second option is to use a surface that was obtained from a surface guided system at the CT sim. This surface may be kind of patchy or lower quality, but it has the advantage that it could show you surfaces that are not in your CT image, like an arm or a chin. And then lastly is the surface capture there in the treatment room. This is less ideal for monitoring interfraction setup because if it's incorrect, it could lead to systematic uncertainties. However, if this surface is captured after imaging, it's a good reference to monitor intrafraction motion. One challenge is choosing the most appropriate surface ROI. In general, you can start by kind of choosing a large ROI to help with kind of large postural corrections and then kind of crop it down to a more relevant tissue. However, it really does depend on the site and situation. So here on left, you can see a case where this large ROI failed to detect that there was significant breast swelling, but the small ROI actually correctly detected there was a large magnitude difference. And then in the middle is a case where the small ROI was saying they needed a 7mm shift, but actually if you made a much larger ROI covering the whole chest, it correctly recognized that this patient actually needed a 3-degree roll. And then there may be cases like this one on the right where you want to remove all the more mobile breast tissue and kind of just focus on tracking the chest wall. After the patient is set up, the SGRT can be used to monitor intrafraction motion as well. For breast, for example, the surface can be monitored to ensure that the patient is maintaining proper breath hold. And if at any point the surface is detected to be out of tolerance, then it will automatically turn off the beam. Another challenge of SGRT is that the surface is only a surrogate for the target motion. So you're gonna have to evaluate its usefulness for each site carefully. The accuracy is also sensitive to cameras being blocked from viewing the patient, as you can see here. Patient's skin color, as you can see in the middle image, the gain had to be adjusted to better detect a patient with darker skin tone. And then on the bottom, you can see that the calculated shift can drift as the cameras thermally warm up. Additionally, there's just a strong learning curve for new SGRT users. All right, so lastly, I'm gonna briefly mention MRI guided therapy, since I think it's likely gonna be a very important future direction in our field. Currently, there are 2 MR Linux that are commercially available, ViewRay's Meridian and Electus Unity. And MRI guided therapy is promising because it can address several of these challenges that we've talked about earlier. So firstly, these machines allow us to set up the patient using a 3D MR image right in the room. Obviously, MR is going to give us superior soft tissue contrast compared to a cone beam CT, and this allows us to align the target more precisely. Secondly, we can acquire 2D Cine images during the irradiation to gate the treatment. As we discussed before, one weakness of other gating techniques is that we're tracking based on a surrogate, like the skin surface or a marker, but now we can actually track the target itself. So here you can see that when the beam is turned on, the beam is only going to be turned on when the target is in the boundary structure. And kind of even more impressive in this example is that you can see that when their breath hold was slightly off, they were coached to exhale slightly, which put the tumor in the right spot, which means we can significantly reduce our treatment margins to better spare nearby normal tissues. And another way MRI guided therapy can be can help significantly improve the therapeutic ratio is online adaptive treatments. So here you can see an example of a pancreas treatment where initially the bowel sparing had to be prioritized over the target coverage. However, on the first day of treatment, the bowel moved away, and the plan that was recalculated on that current MR was suboptimal. So the bottom row shows that an adaptive plan made while the patient was on the table, the coverage was able to be drastically improved. So this has the potential to kind of shift our whole paradigm of how we deliver radiation therapy, allowing us to escalate and de-escalate doses based on the proximity of the normal tissues that day. While MRI-guided therapy is very exciting, there are some challenges. MR systems are complex and expensive. Treatment times will likely be longer if you're using gating or online adaptive treatment. There's patient contraindications like implanted devices, patient size, claustrophobia. MR images can suffer from distortions, and also the dose distribution can be influenced by the magnetic field. And then probably one of the most important challenges is that these machines require staff to be knowledgeable in both MR and therapy. And conventionally, there's been some separation between diagnostic and therapeutic staff. So I think this distinction is going to be kind of more blurred as time goes on. All right, so in summary, high quality imaging in radiation therapy is important for the accurate delineation of tumors and normal tissues, accurate dose calculations, and accurate patient and target localization for treatment. Some of our biggest challenges are motion, high-Z materials, and soft tissue contrast. But have no fear, medical physicists are on top of it, and we have lots of techniques and methods in our toolbox to kind of help overcome these challenges in both the CT simulation and the treatment. And then just lastly, it's important to quantitatively validate each technique you're going to use before use and kind of fully understand its strengths and weaknesses for each clinical application. Thank you.